Hello, I'm Dr. Hassan Javed. I'm a GP working in London. Today we are going to discuss microvascular complications of diabetes. This short information video is intended for patients. So let's start. So we are going to discuss the microvascular complications of diabetes. So microvascular, as the name suggests, micro means smaller, vascular refers to the vessels. So these are the complications of diabetes which involve wherever in the body we've got smaller vessels. The three recognized ones are the diabetic retinopathy, which involves a part of the eye, diabetic nephropathy, which refers to complications of the kidney, and diabetic neuropathy, which involves the nerves. While there are other complications such as the macrovascular ones, which are common in many other conditions as well, these microvascular complications are very specific to diabetes, and we are going to see each one of them now. This is the side view of the eye now. So from the light enters from the cornea, goes through the lens, and the image forms on the back of the eye on a structure called the retina, and a special part of the retina is also called macula, where the central part of the image forms. So the diabetes affects the blood vessels which supply this part of the eye, and hence it is called diabetic retinopathy. So what is this diabetic retinopathy? What is the cause? So basically this structure called retina at the back of the eye has got a rich supply of blood vessels, which gets damaged if your blood sugar readings or your blood pressure are persistently high. And what it will cause is it will cause the blood vessels to either leak or get blocked, or they can start growing randomly. So it is prolonged higher readings of blood sugars and not a good control of your blood pressure that will over years damage these vessels and cause this retinopathy. And how common is this? So basically around 4% of a UK population who have got sight loss have actually got diabetic retinopathy. It is slightly higher in type 1 diabetics as compared to the type 2 diabetes. So the type 1 diabetics are basically having around a percentage of 50% of these patients, and it's around 30% of the patients who have got type 2 diabetes that would have some stage of diabetic retinopathy. And am I at risk? Yes, both. If you are a type 1 or type 2 diabetic, so you're both at risk. No matter what type of diabetes it is basically, as we said, it is the reason is the long duration of the diabetes, which has been uncontrolled, and along with the blood pressure, and that is what causes the risk of diabetic retinopathy to develop. So associations and risk factors other than poor blood glucose control and high blood pressure are increased protein in your urine, prolonged diabetes we've already discussed, and high cholesterol levels in the blood, and if you're Asian or Afro-Caribbean in origin. With regards to the symptoms of diabetic retinopathy, some patients can notice gradual worsening of the vision. They can also notice a sudden visual loss, or some floaters which come into your eye field in your vision, some blurred or patchy vision, and sometimes eye pain or redness as well. So if you get any of these symptoms, you do need to see your optician at least. With regards to diabetic retinopathy staging, broadly, it can be divided into two parts. One is non-proliferative, which is minor damage to the blood vessels, which may bleed slightly. Usually there will be no visual changes, or you might have some symptoms present. The second one is the proliferative retinopathy, which is basically when there is scarring and new blood vessel formation, and these can easily bleed, and this is the one which can lead to vision loss or blindness. Again, maculopathy, which means that the part of the retina at the back of the eye, which is responsible for the central vision and for our fine detail of the images, is affected. Coming to the treatment for these, so the treatment depends on the stage and the symptoms present. Laser photocoagulation can be used, which can often prevent this from progressing to blindness. Now, what is a retinopathy screening? So this is when your optician looks at the back of your eye, called the retina. So basically, they will have a look by putting some drops into your eye to dilate your pupils so that they can clearly see the back of the eye. They will take the pictures. These will then be sent to your eye specialist if you're already under them, or otherwise they're going to send you a report within a month's time. Normally, after you've had the retinopathy screening done, which is done annually, the optician will advise you not to straight away get up and walk out, because your vision might be blurred. It might be not safe to do so immediately. So the treatment of diabetic retinopathy is dependent on the staging and the features present, which includes laser photocoagulation, eye injections, and surgery. Coming to the misconceptions, some patients say, I did not attend my clinic, but I had my eyes checked and my glasses were changed, or I had this and that with my eye, and there was pain in the eye, and I was seen by the optician only 3 months ago. So no, these are not part of the diabetic screening program. Having attended your optician for a change of your eye lenses or glasses, or for having some redness of the eye, is not part of the diabetic retinopathy screening, and you need to attend annually specifically the diabetic retinopathy screening appointments as part of the management of diabetes. The next microvascular complication of diabetes we are going to discuss is diabetic nephropathy. As we discussed, nephropathy means with relation to kidneys. So humans have got 2 kidneys, and the basic unit inside one kidney is called a nephron. So a nephron, there are about 1 to 1.5 million nephrons in one kidney. So the damage to these nephrons would result in a condition called diabetic nephropathy. So diabetic nephropathy, what is this? Essentially, this means deterioration of proper functioning of the kidneys. A molecule called protein is measured in your urine. This should normally not be excreted in larger amounts. Initially, you see a smaller amount of protein, which is called microalbuminuria, which then progresses on to more protein excretion called proteinuria, in which case there is more than 500 milligrams of proteins present in 24-hour urine sample, which can then go on to overt diabetic nephropathy. What causes this? It's actually a combination of high blood pressure and poor control of diabetes that can often lead to damage of the kidneys. And can I get this? Can I prevent this? Yes, both type 1 and type 2 diabetics can get diabetic nephropathy, and how they can prevent this is by keeping the blood sugar levels within target range, keeping your blood pressure down. If you're smoking, get support to stop this, eat healthy and keep active, and go to all your medical appointments. Diabetic nephropathy stages. There are 5 stages of diabetic nephropathy. The first 3 are normally managed by your GP, and they can include some possibility of medications and lifestyle changes. The 4th and 5th stage of a diabetic nephropathy, you're normally referred to a specialist called a nephrologist or a kidney specialist. And the last stage of diabetic nephropathy is also called end-stage renal disease. Now, coming on to the symptoms, it is important to note that initially, when a patient develops diabetic nephropathy, they might not have any symptoms. However, as the condition progresses, they can note to have some swollen ankles or feet. They can notice some blood in the urine, and they can feel excessively tired. They can feel short of breath as well, and also they can feel nausea or sickness symptoms as well. So, monitoring diabetic nephropathy, it involves an annual blood test called a renal function test, which looks for a waste product called creatinine present in the blood. Again, another test is a urine test called the albumin creatinine ratio, or ACR, that looks for the protein which is leaking into the urine. Now, coming to a very common sort of scenario, and this is why I want to stress this more, is patients say, doctor told me my blood test showed slightly altered kidney function, but they will monitor. I'm concerned. Do I need to do something about this? So basically, first thing, again, make sure if they've asked you that they are going to monitor, they will tell you how frequently they are going to do the blood test and the urine test, as we have mentioned above. And that frequency will depend on the results. Now, the kidney function reduces gradually over a period of years, or say about decades. The treatment offered will depend on how serious the problem is. So it is important when they've mentioned to you that your kidney function is slightly altered, just ask them if they can give you a copy of the results, or if you can go through them, and also check your medications to see if there are these medications, any of these medications already that you are on. If you're not on them, then have a discussion. So these are belonging to the class ACEI or ARB, and basically these are used for control of blood pressure, but they also have a very important role in preventing progression of diabetic nephropathy. So have a look through your medication list to see if any one of these, from ramipril, lisinopril, candesartan, losartan, valsartan, telmisartan, if you are already on any one of these. And these are the common ones used for managing progression of diabetic nephropathy by your GP. Moving on to diabetic neuropathy. So what is this diabetic neuropathy? First of all, it's important to understand what is peripheral nervous system. So it is a network of nerves which transmit information between the central nervous system and all other parts of the body, including your arms, the legs, and different organs. Now, the symptoms of peripheral neuropathy will emanate from the type of the nerves which are involved. In sensory nerves, these are the nerves that carry messages of pain, touch, temperature, and sensation to your brain. Similarly, if these nerves are affected, you will get tingling, numbness, unable to feel pain, or changes in temperature, and also being unaware of how to coordinate the movement of a particular joint. And especially the more important one is the burning or the shooting pains, which normally tend to be worse at night, especially in the limbs. Again, motor nerves, if they are involved, these are the nerves which cause, if there is damage to these nerves, it will cause weakness and wasting of the muscles. Autonomic neuropathy involves the nerves which are responsible for autonomic nervous control, which is involuntary actions such as the beating of your heart. And hence damage to these nerves can result in problems with function of your gut, lower blood pressure readings, and a patient not being aware of low sugar levels in the body, loss of bladder control, problems with swelling, and in men, problems such as erectile dysfunction. By far the most common, as you can imagine, there will be many presentations depending on what and which nerves are getting involved. But the most common presentation of diabetic peripheral neuropathy is chronic sensorimotor distal symmetric polyneuropathy, which means chronic means it's a long-term condition. Sensorimotor means involves the sensory and motor areas, and distal means the lower limbs. So symmetric means, and as you can see, it will come in the same, so in both the legs, in a similar distribution, equally. Hence, it is symmetrical. And polyneuropathy means it involves several nerves. So it will typically result in the burning or shooting pains, which are typically worse at night. And this is by far the most common presentation of diabetic peripheral neuropathy. Diabetic neuropathy, how common is this? Both type 1 and type 2 diabetics, diabetic neuropathy is a common complication of these. More than half the people in type 2 diabetics who are more than 60 years have basically noted to have been having diabetic neuropathy symptoms. Who is more at risk? Again, like other microvascular complications of diabetes, the duration and magnitude of hyperglycemia, how long you've had the diabetes, and how poor the control of the diabetes was, will contribute to having this complication. Again, other associations are increased weight or being overweight, having a poor control of your blood pressure, having a history of coronary artery disease such as an angina or a heart attack, and if your patient is smoking. So how to keep an eye on your distal symmetric polyneuropathy? Firstly, attend your annual feet check appointments at your GP surgery. This will involve sensation check with a 10-gram monofilament test they would do and you would be aware of. Again, ask your surgery or your diabetic nurse if you can do some home checks, including something called the Ipswich test, in which you can test your sensation of your feet yourself, or your carer can do this. Again, follow foot care and shoe wear advice, which includes includes that you look carefully at your feet each day, including between the toes. Always wear your socks with your shoes or your other footwear. Do not walk barefoot, and do not try to treat your any corns, calluses or verrucas or ulcers on your own. And if you've been advised to see a podiatrist, please do not miss any appointments. Moreover, sometimes if you are under their routine care, they can also spot and manage any foot issues quite earlier than you would be able to spot yourself. So don't miss any appointments with your podiatrist. In terms of the medications, it depends upon the symptoms of neuropathy. For example, if it was for any sickness symptoms, then you will be given anti-sickness medications. Again, men can be given medications for erectile dysfunction if that is the cause. And coming to the neuropathic pain, which is the pain present, the medications are called neuropathic pain agents, and these can include medications such as amitriptyline, nortriptyline, pregabalin, gabapentin, and these are the common ones used here in the UK. With regards to medications for diabetic neuropathy, common misconceptions is patients report that we have been using paracetamol, ibuprofen or codeine, and it makes no change to the burning pain or different polyneuropathic symptoms they are having. Well, actually, these will not work in neuropathic pain. The medications we have just discussed are the ones which are going to work, and these will have little to no effect on your symptoms. Now, with regards to the concerns, now we do need to understand the common side effects of the nerve pain or neuropathic pain medications. Again, these medications can give side effects including feeling drowsy or sleepy, and basically it is important to understand what the patient's lifestyle is. Are they shift workers or do they drive? And if the pain medication causes sleepiness, check what times you should be taking it and discuss the alternatives with your doctor. Also, dependence with these medications is expected, and this should be discussed when the medications are being started or if the dose is being increased. However, the side effects of these medications can be managed quite effectively in most cases by your own doctors. Hope you've all enjoyed this small information session on microvascular complications of diabetes. Please feel free to have a look at these websites to look more in detail about them. Again, thank you all for watching my video. Hope you all have a great day.